Yeah, we just need to open it to share screen. Yeah, yeah. Yeah, I when we do patient. Yeah. I've got everyone. Which one's yours, Susie? Alice, is on the top. That one? Thank you. Please drag it on the discount. Yeah. Okay, welcome everybody to this session. So my name is Claire O'Reilly. I'm one of the academics here at Sydney Pharmacy School, and I'm co-chairing the session of Claire's as chairs this afternoon with my colleague Claire Anderson from the UK. So we've got another great session this afternoon. So I'm going to introduce our first speaker. So similar as before, these are five-minute talks, but we will be fairly flexible because I know you guys all keep the time. So our first speaker, who gave another great talk already in the conference so far, is Susie Welch, who's a pharmacist, senior pharmacist at St Vincent's Hospital here in Sydney. She's also doing her PhD with Rebecca Moles in investigating Aboriginal and Torres Strait Islander health and hospital pharmacy services. So please welcome Susie. Thanks, Claire. Just before I begin, I'd just like to acknowledge the traditional custodians of the land in which we meet today, the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and extend those respect to any Aboriginal people within the audience today. So thank you. Also, so this work has been published, and I'll put the reference at the end in case I have cut anything short. But presenting on behalf of myself and my co-authors. Two of the authors are employed on Gadigal land and two work on Arakaea land, one of whom is a Yugambeh woman. So just to recap, as I did yesterday, but just for anyone that's new in the audience, Aboriginal and Torres Strait Islander people represent approximately 3.4% of the Australian population, and they live across all states and territories, from metropolitan to rural and remote areas. And prior to colonisation, they were thriving. Despite 200 years of being treated with policy practices based on a deficit model, they are resilient, able to change, survive in the new world, and are still surviving today, and are present and contributing to the community. This is a testament to their strength. So the Aboriginal and Torres Strait Islander concept of health is not just about the individual person, but a whole of life view, which includes the social, emotional, and cultural well-being of the community. And their well-being is strongly connected to country law and community. Disconnection from these as a result of colonisation has had a negative effect on their quality of life and their health. And together with the social determinants of health, this has resulted in health disparity. So a recent literature review found 7 publications which described the role of the hospital pharmacists play in the care of Aboriginal and Torres Strait Islander people. And we hypothesised that perhaps other things were happening out there that we were not published. So we set out to do a project that had the aim to determine the roles of and services provided by Australian hospital pharmacists and pharmacy departments in providing medicines management services to Aboriginal and Torres Strait Islander people admitted to Australian hospitals, and to explore the actual and perceived outcomes. Now, the methods are that it was a mixed method study. There was an online survey and follow-up telephone STEM instruction interview. The survey was emailed to directors of pharmacy as listed in the SHPA or Society directory, and with 4 reminders, and a follow-up semi-structured interview was offered at conclusion. The analysis is outlined there. The interview audio recordings were professionally transcribed. Survey responses and free text were reviewed and coded and tabulated into common themes, and we had ethics approval. So 313 pharmacy departments received the survey, and we had a response rate of 22% or 69, and further 20 pharmacists took up that offer of the semi-structured interview. Of those that were interviewed, only 5 were principal referral hospitals. All hospital categories and states and territories were represented. So results at a glance, only 5 sites stated that Aboriginal and Torres Strait Islander people were a priority for pharmacist review. Work was done under 5 broad themes: culturally safe care. 64% of the sites had specific processes in place. For example, 9 used interpreters routinely. 22 sites had formal links with the Aboriginal medical services. And some sites were addressing the Aboriginal and Torres Strait Islander workforce. Many sites used culturally specific resources, and 57% obtained these from a variety of 57% had used resources, and they obtained them from a variety of sources. This medicines, you can't really see it there, but medicines book for Aboriginal and Torres Strait Islander people was used for a range of medicines. Chronic disease management was a priority in some settings, and continuum of care. So the major focus was on the discharge compared to the admission. And lastly, managing funding models, and I'll elaborate on that in a moment. Outcome measurements of programs were low, and there were some future outcome measures and plans proposed. Just on funding, particularly for the international viewers. In Australia, funding of medicines on discharge from hospital in most states and territories is provided by the Commonwealth Government under the Pharmaceutical Benefits Scheme. The Aboriginal and Torres Strait Islander people can be registered for lower or free medicines under these schemes. However, because of the complexity of funding models between state and federal bodies, navigating this is challenging. And often Aboriginal and Torres Strait Islander people are disadvantaged when discharged from hospital, with a barrier to access to medications with regard to cost. So it was described by respondents that after admission to hospital, extreme difficulties, substantial liaison and different and complex arrangements had to be used by pharmacists to provide access to discharge medicines without extra cost. And this worked around the Commonwealth schemes. 4 interviewees described active advocating for change, which actually produced some outcome in July 2021 after the study was undertaken, but it too still has its teething issues. So just a couple of points within the discussion, looking at diversity and standardisation. Through this work, great breadth and depth of service was uncovered. However, there was diversity across centres and lack of standardisation. And it appears that there's actually room for degrees of both. There's different solutions are needed in different settings, rural compared to urban, and different cultural and legislative settings might be in place. And so diversity is to be encouraged if it's the projects are done with collaboration with and to suit local communities. With regard to lack of standardisation, this actually may reflect a lack of professional governance in this area, and which might be driven, the projects are often driven by individuals. And again, standardisation should be supported if there is evidence that improved patient outcomes can be linked with these themes. Issues that should be addressed in anything along these lines would be co-design. So obviously, we found that projects that were actually co-designed and implemented compared with Aboriginal and Torres Strait Islander people enabled success. Pharmacists' roles in advocating for organisational change, as I outlined with the funding situation, has actually can drive change and reduce institutional racism. Resources, there's work to be done to hopefully get a central repository for resources. There is one currently, but from the respondents, it appeared that there was still work to be done in that. And the fact that the medicines book was used illustrated that there are deficiencies for the existing consumer medicines information format. Now, discrimination and bias occur at many points across healthcare, and this is evidence within our project that only 5 sites actually prioritised Aboriginal and Torres Strait Islander people for pharmacist review. So this is an unconscious bias. Outcomes were few, and evaluation and publication, there were challenges that people outlined with that, whether it was staffing, experience, link with universities, etc. So we have many limitations and strengths, of course, whether it's a point in time or mixed methods was used for useful for helping us understand, but also whether there's some positive bias. And in conclusion then, several sites have pharmacy services or innovations in place to help care for Aboriginal and Torres Strait Islander people admitted to hospital. Outcomes were not routinely assessed, and this work has helped identify the role of pharmacists and pharmacies in providing medicines management for Aboriginal and Torres Strait Islander people, not included in the literature. So wider knowledge, evaluation and measurement of impact of these services on health equity is needed and would allow hospital pharmacy teams to better tailor initiatives to meet the need of Aboriginal and Torres Strait Islander people. Thank you.
Any questions? Silence.
Sorry, I went into the overtime.
Thank you for your very interesting presentation. I really enjoyed that, and I think this is fantastic research. I just have a question with respect to the discrimination, and I wondered what the perceived, how the Aborigines and Torres Strait Islander people perceive Western medicine, because I've heard that it's not always that positively perceived. And I wondered from the pharmacist's perspective, is the discrimination in relation to wondering, how well this is going to be received by the patient?
I think when I talk, well, the fact that only 5 people prioritise Aboriginal and Torres Strait Islander people for pharmacist review is a bias in its own right. I don't think it comes from that angle. I think it comes from how the system is set up. So institutions are set up in an inherently racist way. It follows the white model of healthcare as opposed to a traditional model of healthcare. We did see that 4 sites had a policy to do with traditional medicines within the hospital, but the fact that most didn't is quite a institutionally racist concept. So I think that it's actually more how things are set up and that we need to switch it. So, I mean, traditionally healthcare is quick, which actually doesn't really sit well with the model of care, from what I believe, to be able to provide it correctly to people. Does that answer your question?
I'm wondering also with identifying Aboriginal and Torres Strait Islander people an issue with the way records are kept or with the way they self-identify as well. Like to comment?
Yeah, I would. Thank you. So yes, look, that is actually one of the first points. Okay, do we know if Aboriginal and Torres Strait Islander people are within a hospital? So we did ask that question. I didn't elaborate on it, but in many sites, people knew that it was a mandatory question when people come to hospital in Australia. Do you identify as Aboriginal and Torres Strait Islander, and it's up to the person to feel comfortable if they want to identify. And then from that, wherever it might be hidden, to find out for the health professional to know whether a person has identified or not. So hospitals did it in different ways. Sometimes it was just tucked away in the notes, so you had to actively go away, compared to some hospitals it was actually very visual, and so people could know straight away, and then it would help their interaction at the bedside.
Okay, thank you so much, Susie. Well done.
Yes.
Okay, I'm going to introduce our next speaker, who I know well. Linda Doe is one of our academic tutors here in the school. She's also an experienced hospital pharmacist, and she's doing her MPhil here, looking at entrustable activities of pharmacy students. So please welcome Linda.
Thank you, everyone. Thank you, Claire. And Claire. So I'm Linda. Just for those who weren't here for my first talk, I'm Linda, and I'm just going to speak to you guys about student-led medication history taking in the hospitals as one of our entrustable professional activities that we've introduced to our pharmacy students in the recent years. And I'm just analysing the feedback that we've been receiving from our stakeholders. So just in case, just rehashing briefly on what is an entrustable professional activity, in the sense that these are activities that we've trained students from the classroom, send them out, mark them competent, obviously, and then send them out to the hospitals to take medication histories, either with minimal or no supervision at all from the pharmacists themselves. And it's that fact that we trust these students to take on the medication history taking skills and bring it to practice. And it's the idea of getting to that higher level of doing on the Miller's pyramid there on the educational framework. This is what the progress has been like so far. We started back in prehistory of 2018, prehistory is my MPhil, that is. 2019 was when I started the MPhil, and I've been evaluating it ever since. And I guess recent years, interestingly, we got hit by COVID. First year, obviously 2020, we got hit by COVID. Lots of changes to workflow, let alone on the workplace level, let alone this program itself. So that was the impact, and we can see lower numbers all around there. And then in 2021, we thought COVID obviously was still around, but the hit of, I suppose, the vaccination rollout definitely impacted on our workflow at the hospital level too, increasing clinical work demands for the pharmacists on the ground. So I guess generally speaking, pre-COVID versus COVID times was when you can see numbers of students definitely reduced, duration was definitely reduced, and then also the outcome being the reduced number of histories as well. And I think it's just something to note that everything just got reduced and affected completely by COVID. And the qualitative research behind it is I've been collating, I guess, feedback from stakeholders, students and preceptors in the form of focus groups and interviews. And this is what the picture looks like. I've had the pleasure to interview or hold focus groups for 18 students and also 9 preceptors over the 2 years of COVID, 2020 and 2021. Crunched it all together, bringing down to the themes I'm going to present to you today. So in terms of I kind of split it off into student themes, preceptor themes. So in terms of student themes, I'm just going to, just in interest of time, I'll just summarize the quotes that are shown there, but feel free to read. So in terms of the first theme, workflow changes. So I guess students have noted the fact that over the COVID period, changes of preceptors was more often of a thing. Like, I guess notably some of the students were saying how they went through 3 different pharmacists over a very short period of, you saw about 6 to 7 weeks, which is average of 8 different pharmacists every 2 weeks or so, which is a bit much. And it meant that, what did that mean for them? Obviously, it meant reorientation, relearning a new workflow and trying to integrate into a new preceptor workflow. But however, obviously, as that is a negative, however, the students were very resilient to get away from that by adapting to new changes as they come along. So I guess that's pretty positive to hear, and I'm very proud of the students for doing so and taking on initiatives for that. Obviously, COVID restrictions during the very heavy lockdown times, visitors were not allowed in the hospital. That took away one source that the students were able to take histories from. But obviously that doesn't stop them. They can still call up the carers if they could, but that just meant another phone call, which may or may not even pick up, as we understand. But students really understood the idea during COVID is all about being flexible, and if they're flexible, they're helping the hospital, is helping everyone. And that was the mentality moving forward for students. Communication issues, obviously, with all the PPE, masks on, even like face shields, even in the heavier wards and all that. And also obviously adhering to social distancing of the 1.5 meter 4 square meter rule sort of idea. Students definitely found it very hard to speak to some patients, such as those who are hard of hearing, perhaps. And notably, and it's very interesting, students obviously learnt very quickly that patients who are hard of hearing, they relied very heavily on lip reading. So obviously, if you're covering up with a mask, you can't really see the lip. So what do they do? So I guess some of them, yes, they did take off that mask, obviously stand further away, and then speak to the patient as best as they could. Otherwise, they just spoke as clearly as they could, projecting as well as repeating themselves until this patient gets it. And I guess this emphasized another value, that students were able to empathize, flew onto all these things, but also putting that patient care factor forward. And I guess, why was I highlighting certain parts in the previous slides? You might be wondering, and I guess it boils down to this theme, and a theme is how I'd like to say it. So resilience despite challenges. And that was a very key thing that the students were putting through. Despite challenges, they put workarounds around it, and it was amazing to see that happen. And therefore, it really reduced that burden of COVID on their workflow and the experience, and everything turned out to be an interesting experience, a positive experience moving forward for the students. Pharmacists, in terms of workload, obviously vaccine rollout was a main thing in 2021, but obviously clinical workload doesn't stop, doesn't get compromised either. It just only gets added, and that was one of the main concerns. Students were very empathetic towards this as well. Student ability was actually something that was interesting, that was brought up over the COVID period in terms of virtual learning, was probably something that was more or less noted in terms of knowledge gap, ability gap, say navigating the electronic medical records. Something that used to be quite hands-on training turned into virtual training. Students, when they got into the workplace, they weren't able to apply or weren't able to work as well as it could have, and as well as the fact that maybe students' work experiences were quite reduced over the COVID period as well. Significance in a nutshell, moving forward, we know that pandemic, this is not the last of it, and we know that moving forward, COVID is still around. We need to still continue education, experiential workplace experiences and all that. So I guess it's the refinement of the program, and I guess further support from both preceptors and students, and working together to make things work. Further to this, I wanted to emphasize the fact that obviously we know that this program is feasible during the pandemic times in Australia, because COVID-19 was quite under control. Not sure if this will be same in other countries and translatable, but there will be workarounds, and I'm positive about that. Just want to say thank you to everyone for this. Thank you. Sorry, I ran over time.
Thank you. Any questions for Linda? I've actually got them. Do you assess them and OSCE them before they go out so that they're ready? Because from some of those quotes, it sounds like the preceptors felt they had to train more. And I was interested, is it really an interestable practice activity or
Yes.
not?
Yes, obviously I skimmed over the nitty-gritty of it, but basically students they get trained in the classroom, trained by me in a 2 to 3 hour virtual session, which is quite tedious. Then they get assessed in their classroom based on a simulated competency assessment. Once they get marked off, then they're allowed to go to the hospitals, and that's literally the entrustment from the university end.
Okay, thank you very much.
Thank you.
Thanks. Which one's yours?
Yeah,
Is this this one?
yeah,
Okay.
that's the one.
Okay, so for our next presenter, we're welcoming Eob, who's joining us from University of Western Australia, who's going to talk about non-adherence to atrial fibrillation guidelines. So please welcome Eob.
Good afternoon, everyone. My name is Eob. This is my wonderful supervisory team, and I'll be presenting the work which is part of the mixed method study. And I presented the second part yesterday, so this is the preceding part of my mixed method study. So this is the reasons for non-adherence to atrial fibrillation, thromboprophylaxis prescribing guidelines in Western Australia, and it's a qualitative descriptive study of general practitioners' views. Yeah, okay. Maybe a familiar slide for some of you who attended my presentation yesterday. So atrial fibrillation increases the risk of stroke and thromboembolism by five times, and we use oral anticoagulant medications which reduce this risk by 70%. So we have clinical guidelines to guide the rational use of these medications, and these guidelines recommend the use of oral anticoagulant medications in patients with moderate to high risk of stroke, and no therapy in patients who are at low risk of stroke based on the risk stratification tools. So adhering to the recommendations of these guidelines is knowing to improve patient outcomes in terms of morbidity, mortality, stroke, and others. And however, unfortunately, guideline non-adherence primarily under treatment is very common. There is also over-treatment, but it's only in a small proportion of patients because of focusing more on bleeding risk than the risk of stroke. As you know, general practice is the gateway to the Australian healthcare system, and as such, GPs are the primary service providers here in Australia, and they are highly involved in the long-term thromboprophylaxis management in patients with atrial fibrillation. However, there is a clear evidence to practice gap in terms of under-treatment. There is OAC non-prescription in a large segment of eligible patients, as shown in this figure. Around 45% of patients who are eligible to take anticoagulants do not receive these medications for various reasons. So our aim was to explore the reasons for this non-adherence from the perspectives of GPs working in Western Australia. So the study was conducted from November 2020 to February 2021, and we followed the CORQ guideline to guide the reporting as well as to inform the design of this study. So we used various methods to recruit participants with the help of social media, but also RACGP and also direct contact whenever possible. And we conducted semi-structured interviews, both in person as well as virtually via the Zoom function, depending on the participants' preference, and because we were also in the COVID era. That was also taken into account. And the interviews were transcribed using an online artificial intelligence platform called Otter, but of course they were also double checked by two of the researchers. We use data saturation to inform the final sample size, and we use the framework method and by using in vivo to analyze the data and to generate themes. We used various methods to ensure quality, starting with piloting the interview guide, but also using analyst triangulation, negative case analysis, peer debriefing, as well as the keeping audit trail. And finally, we try to map these findings into the behavioral framework called the COMBI model. So coming to the results section, we invited 10 participants, and after one of the participants declined to participate, 9 GPs took part in the semi-structured interview. So 2 themes emerged from analyzing the interview transcripts. The first one is patient refusal to take these medications when recommended by the doctors, but this is only in a small proportion of patients. So some patients, despite adequate explanation, they simply refuse for various reasons. The second theme was GP's decision-making process, which was divided into 4 sub-themes. These include limited GP's familiarity with these guidelines. So they sort of base it on their knowledge instead of the guidelines. Limited difficulty balancing the risk versus benefit, which was described as a catch-22. So prescribing will lead to bleeding and not prescribing will lead to stroke. And difficulties accessing the cardiologist. This is particularly true in patient through the government system, which could take even months before a patient can see a cardiologist, but that was not an issue with private cardiologists. And difficulty with communicating with patients was also one of the sub-themes. Also, we mapped the findings into the COMBI model. I'm not going to go through the details of this, but as you can see, psychological, so all 3 of the domains were affected in guideline adherence, mainly with reflective motivation, physical and social opportunities, including patients, and the GP's capability, psychological capability also came to play. So this study, of course, has some limitations. As I mentioned, this was conducted only in WA, so that's one limitation, and it's also based on self-reported responses. So that is another issue. However, we believe this adds to the limited Australian data on the reasons for non-adherence. And in conclusion, so sources other than atrial fibrillation guidelines were predominantly used by GPs in prescribing oral anticoagulants. The major challenges were decision-making process for the GPs, and there's a gap in using the formal bleeding risk assessment tools. Patient refusal sometimes plays in part, contributes to guideline non-adherence. So this study is published in Thrombosis Research if you are interested in reading more about the findings. And I would like to thank the University of Western Australia for supporting my studies. Thank you.
Thank you very much.
Yeah.
Thank you so much. How challenging it is to have samples from GPs?
Well, if you are planning to do research, try not to do it with GPs. But yeah, unless you have a really good network of contacts, which can help you with the recruiting process. But otherwise, it's a very challenging cohort of people to recruit. Yeah.
Thank you for a great presentation.
Thank you.
WA's had some success with pharmacists in general practice.
Yeah.
Did any of the GPs talk about that and the potential influence of pharmacists?
Yeah. So I didn't include this presentation, but there was one or two of the participants, or that means the GPs, mentioned that having a GP pharmacist really helped with the prescribing and also patient counseling. But having said this, they also mentioned that some patients tend not to listen to the pharmacists because they are not doctors. So it's good because they give them time and can collect a lot of information and empathize. But on the other hand, there is also a tendency for some patients not to fully trust them in terms of listening to the recommendation. So there is a pros and cons of that. Yeah. Yep.
I have
Sorry.
a question on the risk benefit analysis. You picked up that as being an issue for the decision about whether to prescribe or not.
Yeah.
How could that be addressed, or have you thought about that
Yeah.
as an intervention?
So this is a qualitative descriptive study. So I tried to stay to the surface level as much as possible to reflect GP's thoughts and experiences. But having said that, so of course, there is a difficulty of balancing risk versus benefit, but GPs tend to focus more on the bleeding risk than the stroke risk. So that's why there's a large segment of patients being undertreated for fear of bleeding. So the guideline recommendations are to focus more on the stroke risk and use the risk assessment tools to identify patients who are at risk of bleeding so that we can modify the modifiable risk factors. So this report, the challenges are from GP's perspectives, but definitely we should inform GPs to focus more on stroke risk.
Thanks, Ian. I just have one more question. I'm quite interested in that the GPs are quite concerned about the bleeding risk, and I wonder, I'm not familiar with the literature or if you talk to consumers about this, but does it match with what the consumers are concerned about? Does the GP just say that because the patient comes to them worried about it, or is it from a GP?
Yeah, so that's an interesting question because so the themes, one of the themes was patient refusal. So we are currently conducting qualitative research to see the patient's perspectives. So there are some patients who are afraid of bleeding, mainly because of the association. Most patients know warfarin, but not the drug. So because of that, there are some patients who are fearful. But having said that, most patients, close to maybe 90 plus within the quantitative study, but they tend to be reliant on GP. So if the GP puts it in a way that there is high risk of bleeding, then they tend to not to accept. But if the GP says there's the bleeding risk, however, the risk is minimal, but the benefits outweigh, then patients tend to accept. So yeah,
Yeah,
very
good. Yeah, great. All right.
Great, thank you very much.
Okay, so for our last speaker in this session, I'd like to welcome Alex Burke. And you might have heard from Alex again, has done another presentation already. So Alex is a Raju male who's currently doing his PhD here in the pharmacy school, looking at cultural competency, cultural safety in the curriculum. So please welcome Alex.
Thank you, Claire Squared, for hosting this event. Yep. So my talk today is going to be on examining Aboriginal and Torres Strait Islander cultural content in Australian pharmacy schools. I did a qualitative study on that. So, and just before I start, I'd like to acknowledge the traditional owners of the lands in which we meet today, so the Gadigal people of the Eora Nation. I'd also like to acknowledge that elders past, present, and emerging as well. So, Aboriginal people don't necessarily feel safe seeking healthcare in Australia. So as Susie spoke to before, there's a lot of discrimination in the workplace. And they did a study in Victoria and they found that actually 90% of the participants in that study had actually experienced racism in the past 12 months. And they did a study in 2017 in Victorian Hospital, and they found that Aboriginal people still consider them places of trauma. And so, and looking into that and looking at ways to actually improve those outcomes. So the APC, the Australian Pharmacy Council, has actually mandated, or to become an accredited school, you have to consult Aboriginal people, and the curricula actually needs to be created that promotes cultural safety and improves health outcomes. And so as all of us know, the joys of going through accreditation processes, you sort of just done it. So the new, all schools have been going around and being assessed against the new accreditation standards. And something that you may not have heard of as well. So the document created by the Australian government in 2014 called the Aboriginal Torres Strait Islander Health Curriculum Framework. It was actually a resource created in 2014 to help all health schools to be able to better embed this content in their curricula. And what it is, so it's made up of 8 principles. So principle 1 is leadership at all levels is key to supporting effective implementation. Principle 2 is respectful partnership and collaboration. Principle 3 is about the process of learning is equally as important as the content that's actually in it. So the self-reflexivity and humility development, respectful of healthcare practice. Principle 5 is holistic health service delivery is actually essential. Principle 6 is about local context and diversity must be recognized. Principle 7 is about the development of intercultural capabilities as a lifelong learning journey. And principle 8 is about ongoing professional development and professional support for Aboriginal and Torres Strait Islander people and non-Indigenous people as well. So the aim of this study was to see and to explore academics using Aboriginal and Torres Strait Islander health and cultural safety content in actual farm school curricula and actually ways we can inform recommendations for future curricular changes. So how the study was conducted, so we got it through University of Sydney HREC, and then thanks to the Australian Pharmacy Council, they provided us a list of all the pharmacy schools in Australia and their key contacts, which were the heads of schools. And then interviews were recorded with them through semi-structured interviews, and then they were recorded and then they were transcribed verbatim through a third-party transcription service, rev.com. And then the interviews were then coded against the Aboriginal and Torres Strait Islander health curriculum framework, and then also against the framework analysis, which is the analysis that actually used to help you discover new things. So it's made up of 4 areas. So it's contextual, diagnostic, evaluative, and also strategic. So just before we get into the result, I just want to everyone know that this isn't an indictment of any of the schools. This is a way to go forward and be able to make sure that everything that we can all get better in the future. So we got 22 interviews and all 18 pharmacy schools had a representative interview, which I've heard is quite difficult to do. So what we found that generally across the board, schools are actually having trouble with half of the principles. So principle 1, leadership at all levels, respectful partnership and collaboration. They're having trouble with the process of learning is equally as important as content, and also holistic health service delivery. And we found as well that there's some mixed ideas about how this content should be taught. So most schools were unanimous that this should be taught by an integrated method, but there were some schools who did it via discrete unit, and there were some as well who did discrete in the first couple of years, and then they did integrated throughout the later years. The one area where schools were very, very split over was actually placement. So 8 were in favor of doing mandatory placements. 5 weren't in favor of any mandatory placements because they could be seen as a form of cultural tourism. And then a couple other schools either had no opinion or they weren't sure about what to do. But again, all in favor. Most schools wanted to move away from multiple choice questions or short answers to essays and oral-based exam question, oral-based assessments. And with that as well, a lot of them also want to make sure that if you weren't culturally safe in those oral assessments, you couldn't pass the unit and you have to redo them. So in saying that though, so is what we're doing enough? And so my opinion as a Wiradjuri Aboriginal person, I think it is. So the APC and the government have actually laid out very set frameworks about what needs to be done. And the schools are meeting to varying degrees. So some are just saying that the APC accreditation guidelines are enough, and others are saying that no, we need to do more. And there's no real standardization across the board. So someone in one university could be learning something completely different to what's in another university. And this method is good in a sense because it could be used to identify gaps broadly. But one of the limitations that is that because we only got to interview most of the time the heads of school, we only got one perspective. And in the cases where we got to interview the heads of school and someone in the faculty as well, there were very different ideas about what the school was doing. So some thought that the heads of school thought what they were doing wasn't enough, or that what they were doing was enough. And when we interviewed someone underneath, they said either yes, we are doing enough, or we aren't doing enough. So yeah. And so in conclusion, so whilst cultural safety was taught in pharmacy schools, there were disparities in teaching, but some ideas for future improvements were uncovered as well. Just before I finish, I'd like to acknowledge the Australian Pharmacy Council for providing funds for this project, especially to cover transcription costs, because they are expensive. Glenys Wilkinson's here today, but I'd also like to thank Josephine and Bronwyn as well. I'd like to thank all the pharmacy schools who took part, and also my PhD supervisors, Rebecca Moles and Bandana.
Any questions?
Yes.
Thanks, Alex, for the presentation. I could definitely have asked you this up in our level 5, but I was asked you here. I suppose in terms of different schools, obviously you had a mix of different schools and different opinions on how well did they achieve their ABC accreditation standards and cultural competency and all that. Did you believe that, perhaps this is a leading question, but do you think it's partially molded by the population of students, that the demographic of students who might be at the schools, potentially different ratios of Indigenous, Aboriginal, Torres Strait Islander students?
So I don't think so. So generally the rural schools, it was a mixed bag. I said rural school, it was all over the place. So a lot of schools either did some things really well, other schools didn't do things that well. I'm being very careful because a lot of the interviewees, they were conditional on their interviews if we didn't name them. So we have to be very careful. So yes and no. So sometimes rural areas did it better, other times rural areas didn't do it well. Big city as well. A lot of the city ones did well because a lot of you may not know, Aboriginal people mainly live in the metro areas. Like the largest population of Aboriginal people in Australia is Western Sydney. So the cities generally, most of the time, did well, but again, it's different across the board. In regards to that, I think as well, when a lot of new like people who had like younger staff members as well, people who are more hip with it, they sometimes, I think as well, because the curriculums in high schools are changing as well. It's a big broad movement in Australia as well, from when I was going through high school versus primary school, when the people now are going through high school and primary school. So yeah, I think it's just the more general jump in demographics and age in Australia. So yeah, it's all over the shop.
Thanks very much, Alex. I've just seen that you're speaking at one of the LIP Network webinars coming up in August.
Yes.
Hopefully you know about that. Do you have any insights into how you think that the LIP Network might help pharmacy schools do better in this space?
So, that was one of the things I asked the schools as well. Did they know about LIP? And the answer was, the big prestigious universities knew about it. A lot of the rural universities didn't. So that's one of the things I communicated with APC as well, was that more broad messaging, letting it know that it is out there. And a lot of the rural universities wanted the opportunity to possibly take part in it as well. They didn't find that they had the opportunity to be a part of it. So yeah.
I'm just thinking of the sort of the circularity of having non-Indigenous staff members, and then the creation of course content that is directed at Indigenous people. I mean, we have an Indigenous health unit, but I just mean generally on the ground. Okay, I have Aboriginal cousins, but I'm white. I know not much.
Yeah. So one of the interviewees raised a really good point. She said, she said that even you might be Indigenous, but and in my case, I'm lucky. I went to university. I went and might have parents who do have good jobs. You need to actually engage people in community, because they're not going to live. They don't live like I do. So they're not as privileged as I am. So having people actually in community to help inform case studies to give a more accurate picture of what people actually go through that's what my PhD is also going to be focused on, actually engaging people on the ground. And doing that, hopefully we can see a better picture of what actual Aboriginal people and Torres Strait Islander people are actually experiencing, and actually create case studies in those areas to help inform curricula and help people get better in treating those conditions with those people.
Okay.
Yeah.
Thank you very much.
Come to the colloquium so you can see the bigger presentation.
Thank you very much. Thank you. 10-minute break. Yeah.
Thank you, everybody.